Hello, everyone. We're ready for the next panel on AI for hospital at home. So as the panelists join me up on stage, my name is Justin Manjourides. I'm a faculty member here at Northeastern in the Bouvet College of Health Sciences. I'm a biostatistician and work a lot in real-world evidence and how we access all the programmatically collected data throughout our lives. I think that will come up today, or in this panel. Joining me, we have a fantastic panel. Starting at your right, we have Hoda Sayed-Friel. She's the former EVP of MEDITECH, which is an EHR company automating hospitals and physician practices as well as other healthcare environments. Hoda is also a graduate of Northeastern and a member of the Bouvet College Strategic Council. So welcome back. Thank you for joining us. Next, we have Colleen Hull. Colleen began her career as a registered nurse and has held leadership roles in hospitals, ambulatory care settings, post-acute care, and population health settings as well. She also launched Atrium Health Hospital at Home, the largest hospital at home program in the country. And then we have Dr. David Levine. He's associate professor and clinical director at Mass General Brigham and a leading expert in home-based healthcare. So thank you very much for joining us, for speaking about this. And just to set the level of what we're talking about, Colleen, would you mind just briefly describing the benefits of at-home healthcare compared to hospital-based systems and how it can help reduce some of the risks associated with traditional hospitalization?
Sure. If you think about it, we delivered most healthcare 100 years ago in homes. My dad was born at home. So in some ways, it's nothing new under the sun. But in the 40s or so, after World War II, we implemented the Hill-Burton Act, and we institutionalized healthcare. And with that came advances in technology and science, and that was all really great. Fewer people died. We were delivering better care. But in that institutionalizing healthcare, we lost some of what matters most to patients, and that's care delivered in the context of their own lives. And when I say they, I mean us. So hospital at home really takes the very best of what we've learned through research and science and technology and marrying that to the caring part of healthcare. So imagine a patient needing hospital-level care. You're in the emergency department. I'm sorry, Mr. Jones, we're going to have to admit you, but we can admit you to your very own bed. So delivering hospital-level care in the home, bringing all that to the patient instead of making the patient force their way into our, or find their way into our systems. We can do pretty much everything short of invasive procedures and surgery. So the benefits, of course, the patient is on their turf. That creates a really important power shift, power to the patient. Whereas in traditional structures, it lives with, frankly, payers, providers, and the hospitals. So you get a power shift. You get the patient relaxed and comfortable in their own setting. They can go to their own bathroom, their own refrigerator. They have their dog and their cat. They can water their own flowers. And most importantly, they're surrounded by their loved ones, neighbors and family members, and someone from the church can stop by and visit. For us as clinicians, we get better than ever visibility into how that patient actually lives. You don't know till you go, I sometimes say. A patient can tell you what they are comfortable telling you from an ED stretcher when we ask them, do you have food? Can you afford your medicine? It's embarrassing to say, actually, no. But when we go into the home, when we can see the truth of how patients are living, how well or how poorly, we could actually develop a plan of care around that instead of what we think the patient needs when really we don't actually know. So I'm a big advocate, obviously. I think it's a win for health systems, for patients, and certainly for us as clinicians.
So it sounds like some of the benefits are really the human aspect, the personal aspect of clinicians visiting and actually observing and taking note of these things and being able to respond. So David, can you give us a brief overview of some of the current AI solutions that are being used in home healthcare in light of sort of what these benefits might be?
Yeah, and also thank you, Justin. It's great to be with you all. Thanks for hanging out so late. You didn't have to stay, so we appreciate it. And I guess I'll also just add on to Colleen's part, which is, what she said is spot on and incredibly important. There are also a lot of kind of hard clinical outcomes that we've proven, over actually like 40 or 50 years. A lot of folks don't realize home hospital has been going on for decades and decades and decades outside of the United States. A lot of people are like, oh, this is something new since the pandemic, right? The answer is no, that's not true at all. Australia and Italy and France and the UK have been doing home hospital for decades. The United States is actually pretty slow to come back to it. We did one of the first randomized controlled trials of home hospital here in Boston to show reductions in 30-day readmission rates, reductions in cost when you're home hospitalized compared to traditionally hospitalized in the brick and mortar. Patient experience levels, like Colleen was talking about, go up, 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 up in those cases. And to get to your question, though, Justin, I think 3 areas that we should all probably talk about and think about are where I think AI can and should be used in, because the answer to your question right now is almost nowhere. We just saw an amazingly broad portfolio of things that John is trying to do at Boston Children's, for example, right? And that stuff has all just happened in the last couple of years. Most home hospital programs today, unfortunately, are not using a lot of technology. And I think that it's an amazing opportunity space for people in this room who want to design and develop for that, because we are super old-fashioned often. And actually, some of the older colleagues who've been doing this in Australia for decades will say, what do y'all need that technology for? Like, this is just old-fashioned care. We just need to deliver care like with really good heart, like where we know we should do things. And I definitely can be in that camp often, and then also want to look at how can we push the care to be even better in patients' homes. So I think the answer to your question is probably threefold. One, AI tools are currently being used for patient acquisition for home hospital. So, we've got hundreds and sometimes thousands of patients in our hospital. How can we find the right ones who can get care at home? And that is often a very manual process right now. You have to look through charts and notes and look at the case manager's note and look at the clinician's note and try to find the right patients for you. There are hospitals, ours being one of them, that is using different variations of AI-based rules. I really love John's slide there of just rules-based all the way out to kind of generative-based. We're using rules-based logic right now at MGB, for example. A fun story, I tried about 5 years ago, before we had good access to LLMs, to get a decent AI algorithm to converge well, and it did not. It totally failed, and the rules-based algorithm beat it like every single time. And so we still use mostly a rules-based algorithm. I think the second place to think about AI in home hospital care is with all of the continuous monitoring data that we have right now. So we have, again, it's nothing compared to many of the people in the room, but we have terabytes and terabytes of continuous monitoring data on our patients, and frankly, we don't use it very much. Our group has validated a continuous monitoring algorithm to look at predicting deterioration in the home, but it's very hard to get our clinicians to use that, just speaking to change management. And then I think the third place that we can be thinking about AI in a big way in this area is in patient engagement and patient communication, because there is a big distance often between our healthcare team and the patient because they're at home. It's really easy for a nurse to just walk down the hall and pop into the room and say, hey, your test results came back normal, or something like that. And I think there's a big opportunity to use a lot of the patient engagement strategies that we see AI being able to develop to actually be that communication valve for us when our patients are in the home.
So talking about the data, the continuous monitoring data, Hoda, so once these are deployed and data is being collected or these systems are used, how are researchers interested in using this massive amount of data that is being collected in the home?
I think the potential of data is vast in this area. So if we think about the data that's being used to train LLMs right now, a lot of it is coming from electronic health records like MEDITECH and Cerner and Epic, which we heard about. So what isn't being fed into these LLMs are data directly from the patient and from these remote monitorings, these wearables and these devices. As we heard this morning, there's 900 different FDA-approved devices that are out there. So we need to be able to take advantage of those things to use them in the home for the patients that we're sending home acutely for hospital at home, or for more chronic health maintenance also. So when you think about that, so how do we use AI with this? So the things that we need to do is sort of fourfold. Number one, for a patient that's sent as an acute patient to be at home, we're going to monitor vital signs and all of those things, like David mentioned, with all of these wearables. We're going to bring that data, and we put an AI component on top of it. Right? So that AI component can do a couple of things, and these are things that are possible right now, so I'm not even making up something that isn't available. That AI component can basically show you a trend, so where you might not want to see every temperature or every piece of vital sign, you might want to see an abnormality in a vital sign. So AI can look at all of this volume of data, because imagine the number of pieces of data that these wearables collect. It's a lot, and it's too much for physicians to look at, so they won't look at it. So the number one reason that they're not using these continuous monitors is, like, your physician doesn't want to see how many steps you took every single day for the last month. They don't want to see that, but they do want to see that you exercise, and you exercise at a certain level. Same thing with these other wearables for treating patients at home. So you want to see their vital signs, and then put that data in front of the clinician. So use the electronic health record that they're already using for patient care, and put it on their dashboard for all of their at-home patients, and show the nurses, show the physicians sort of the trend of data, and then use algorithms that are well known to predict when someone might be decompensating. Right? So you take a look at temperature, you take a look at respiratory rate, you take a look at a bunch of variables, and then be able to indicate to the nurses caring for the patients that they're starting to decompensate, and maybe they're getting septic or something like that. So there are algorithms available where you can do that. So the first set of data would be coming from these wearables and these monitors, and AI living on top of it, and fed right into the EHR. And to be used for clinical decision support and letting physicians know. The other area is if you have to change a medication regimen, why don't you take a look at their lab results that they had while they were in the hospital, take a look at the data that's coming out of the monitors, take a look at their genetic profile to make sure that they can metabolize a drug, and make sure if you're going to change the regimen that they're going to be able to actually metabolize the drug change that you're going to do. So that's one vein. The second vein is all the patients, say, from Boston Children's or Advocate or Mayo Clinic or Atrium, then you take patients and you put that data and their continuous data in a big database in a cloud someplace, right? So you move that data. Now you, in this case, because you want to do more detailed discovery, it's not for direct patient care, it's for research, then you want every single measurement. So you want all millions and millions of data points. You want all of those measurements to be there. Now you're going to say, okay, let me segment the population. Patients that I sent home that had this particular condition, let me analyze how our care plans worked, right? And do that. So then the third avenue is take the patients across all different types of facilities, and this will require a lot of maneuvering that John Halemka talked about, and put that in a bigger database. So now you're going across facilities and not just at a single facility. So see how we kind of went from direct to the patient to groups of patients to patients on a more broad perspective, and then put that in a database for public health and figure out how we're doing in caring for our patients. And that probably is a little bit better for managing chronic disease versus acute disease, but that's how you can use it. And then lastly, how do we use AI on top of those, and then also provide some mechanism and some feedback back to the patient? So it is all about the data, and the interfaces and APIs that are out there right now know how to grab the data from these devices. So that is not the stumbling block. The bigger stumbling block is getting these devices into the patient's home, having them use those devices, and then start grabbing the information to move it into these various databases that will be used for patient care and population health.
So I guess my next question is for everybody, but I'll start with you, Colleen. Is, now we've laid out this setting that seems beneficial to patients. There are potential solutions. What are the unique challenges to implementing these AI solutions in the home-based system as opposed to a hospital-based system?
Well, I can speak just from the remote patient monitoring, and she was just speaking to that. Sorry, my voice just got broken up. It's easy to monitor a patient in the ICU bed. They don't move. And I can be pretty comfortable that the data I'm getting from that patient and the trending is legit because I have full control. Just the nature of caring for patients in their home, just by being in your home, we want them to be up and moving. And they do move better, by the way. They also fall less frequently because they know how to get to their own bathroom. They get fewer infections, less delirium, insomnia. They eat better, move better, sleep better. But now I don't have control over how they're moving. I want to monitor their fall risk. I want to predict their fall risk, and I want to know when they fall, and I want to learn how to mitigate their risk. You lose some control. So that's where I think there's a lot of opportunity to create more sensitive monitoring devices and make meaning of all of that data. It doesn't really do me any good to get a bunch of data points and I'm not able to make meaning of it versus, and I'm an old ICU nurse, I loved looking at all that, and I could track and trend it confidently, but it's just a little bit harder. And then you add the layer of the dog barks and then family in and out. It gets messier, I would say.
Well, and I'll just add to that, like, not only are the devices messing us up, but the algorithms aren't good enough either in the home. Right? Nobody is training on these kinds of, because nobody has these data sets, and nobody's actually thinking about taking care of patients in the home right now, unfortunately, like at this level. And so when you try to apply the ICU algorithm to our remote monitoring data, it doesn't work very well because all of a sudden someone's temperature goes like this, and it's actually because they took the thing off for a second while they were showering. And so all that stuff does not work very well, and that is a huge challenge right now, is that these systems are way, way, way too sensitive, and when we try to apply typical algorithms, I find that they often fail in the home.
So what evidence, would you need to see, would you be comfortable with before deploying some of these tools in the home? Like what would make a compelling case to you?
I can start.
I think we have to start gathering that data. I don't think we're going to know what it is and what works and what doesn't work until we start gathering and just looking at, the noise ratio of some of that data, because there's definitely going to be noise ratios with it, but we don't know yet. And I think, part of the issue and one of the things that disappoints me about large language models is they haven't even moved forward to start grabbing this data. So I'm hoping that, as we get more comfortable with AI in general, that we start looking at patient-generated data more carefully. So whether it's in social media, like some of the speakers that ask questions here today, whether it's off of, smartwatches, whether it's off of other types of devices, that we need to start gathering that and start training our AI models on this different class of data, because it is different. And there's a lot of it. Like if we think about your Apple Watch or your Fitbits and so forth, you know how you see a trend of, if you keep track of your steps, how many of you keep track of steps, right? You see your trend. When it shows you your daily, monthly, yearly trend, guess what that tells you? They're storing your data someplace in the cloud. It's yours. They're not releasing it to anybody else. I don't want anyone to get nervous. But that's the kind of stuff that's out there that we haven't used yet to train any of the AIs that we need in order to move this agenda forward.
Yeah, I think that's a really great point. I'll also just say, kind of as a clinician and a physician, I would expect the same level of rigor to use an algorithm like this that I would for drugs or for other kinds of interventions, and we are nowhere near that right now. We just don't have that level of scrutiny or that level of evidence right now. Has anyone heard of the news score?
Yes.
I know you all have, but there's not very many clinicians here. Thanks, clinician. So it's the National Early Warning Score. The entire NHS, National Health Service in the UK, every single nurse and physician uses the news score in the UK, in UK hospitals. Every single one. It's like, it's okay. The C statistic is like just hovering around 0.86, 0.87 to identify somebody who is going to crash in their hospital. And that's based on 2 vital signs taken a day. That's it. We should be able to do a heck of a lot better than that. Right now, we use news scores often on continuous data. It's crazy. Like, that's the state that we're in, unfortunately, oftentimes in regular acute care medicine as well as home hospital medicine. And so, like you were saying, Hoda, like we haven't unleashed, I think, a large amount of the AI opportunity on these kind of data yet.
So beyond the impact that AI can have on the patient in a home health setting, what about the impact that AI tools could have on families and caregivers? What are we seeing in that space?
I can start with that one. There's a hot debate about that. Some of the critics of home-based care would say you're overburdening the family or the caregivers, and they can't be expected to deliver care. You're just shifting the care from the nurses in the hospital to the patient's home. That can be true. If you are not doing a really robust selection of patients and looking at the whole family dynamic, the willingness and the ability for families to participate, many want to participate in helping my husband to the bathroom instead of a stranger. That's an important part, but you can't forget about the burden of having a loved one in the hospital. You know, I have a very urban-centered hospital, but across the county line, and it's all rural in a skinny minute. And those patients really have a lot of trouble accessing healthcare from acute to ambulatory. This model absolutely is better in many cases, and I would say most, to keep that patient in their community in that familiar space. Often it's an elderly couple, and maybe the wife doesn't drive at all, and her husband's in a hospital 30 miles away. Or a young mother that has 3 children, and one of them is hospitalized. Who's going to take care of these other 2 kids? I've had patients say, you would have had to chain me to the ER stretcher because I don't have anybody to feed my dogs. One lady was like, I just want to water my plants, and my garden's going to die if you put me in the hospital. So, I mean, I go back to what I said in the beginning. What matters most to patients is care delivered in their rhythm of life, not ours. So I think the caregiver burden is a real thing, and we need to address it. We need to make sure we are super intentional about selecting the right patients. But you also got to recognize the stress and strain on families to have a loved one in the hospital.
You know, I'll just add, I think there are AI caregiver tools being built right now. Again, I hate to be like the cynic or the skeptic here, but they're nowhere near ready for kind of like prime time use among the vast majority of family caregivers in the US. But I think they're showing promise, right? And they do have an opportunity to potentially relieve burden on family caregivers, even during the acute care time, post-acute care. There's so many companies trying to build these kind of care assistants, particularly for post-acute care. I don't think we have a great evidence base yet to say that they actually work, but hopefully they will one day.
In your experience, are patients excited to or open to adopting sort of AI tools in their home if it maybe means they get to have home-based care instead of hospital-based care, or is that part of the decision? Is that separate from that decision?
I would say it's not part of the decision today.
Yeah.
Hopefully, like, when we have this conference again in a couple more years, I'll have him back and I'll say, oh my God, everything's AI completely. But as I started out saying, we've seen those hype curves like on everybody's slides, right? There is an enormous amount of hype, and when you actually look at the clinical care being delivered, it is not being delivered through AI mechanisms right now, even in an extremely forward-looking, progressive kind of care model like home hospital, where we are we do infuse a lot of the things we do with technology. I would say it's still not part of the discussion or the decision on the part of a patient to say, oh, I'm not doing that because I don't want to interact with the machine. I would say that's not part of the decision. I don't know what you think, Colleen.
I wouldn't say it's part of the decision, but I've been pleasantly surprised. There's an old paradigm, older patients won't embrace, and I'm talking technology in general, won't embrace technology. They're scared of it. My mom's 83 and she loves her smartphone. So I think we're wrong to assume that once you pass 65, you're not willing or able. Many of our patients say, hey, this isn't so hard, and actually it's kind of cool. I push this button and I get my nurse, kind of like in a hospital, a call bell. So in some ways, I think they've been intrigued by it. I won't say every patient is embraced. It can be intimidating. They have to wear a wearable device, and maybe they weren't used to it. But, I flew here this morning, and everybody on that plane was on their smartphone doing something. So more and more, I think to David's point, it's going to be less intrusive. And that's another thing I think you got to look at. Does this feel intrusive in my life? Are you watching me? We're going to have to wrestle, I think, a little bit with introducing technology. And the other last thing I'll say is, I don't think we need to over-engineer and basically take, and David and I talk about this sometimes, we want to deliver hospital-level care in the home, but we don't want to turn the home into a hospital. Because there's a lot of not right stuff in brick-and-mortar traditional settings. Let's do what is needed, no more, no less, and where AI and technology can help us better care for the patient, great, but it can't actually replace care.
Great.
I actually think, too, it's good to emphasize that although they might feel like they're at home and they're not in a hospital, that someone is watching and that they could reach a caregiver and that someone is watching their vital signs. Because the scariest thing for someone at home getting care or for the caregiver is, what if something goes wrong? So I think, the reinforcement that the devices that they're wearing, that the data is actually being looked at by a nurse or a physician, that they're being monitored, they're just being monitored at home, it's just farther away. Rather than being down the hallway, they're down the street.
Okay, so we have some time for questions. So please find a microphone. And
Hey there again. So you'd agree that data is one thing, but accurate data is another thing, right? And I think if everybody at home, seniors, had Apple products, maybe that would be helpful. But my parents are sent home, and the thing comes by Amazon, a delivery that they've got attached to their body. It beeps 4 times at 3 in the morning. They get frustrated. They're already stressed because they're caregivers, seniors. So it just seems that there's an adoption issue of technology, even well-intentioned ones, right? So I'm wondering, do you think that an incentive can be overlaid to help an 88-year-old actually wear the thing for the intended amount of time? Because the frustration level of the things going off at 4 in the morning, they're fit to be tied. And I just don't know if the great minds realize that the adoption of a senior at home already stressing that this is actually a deterrent where they're like, forget it,
So there's two things. I'll take one stab and then you guys go. There's 2 things. Number one, there is CMS will pay the physician practice for educating the patient on the use of a wearable device if they're going to do chronic disease management. Okay, so there's money for an educator. So that's usually the biggest drawback is, you have to hire extra people to train the patients. Typically, a lot of the hospital at home vendors out there that are working with hospitals, they will partner with like Best Buy, who sends their geek squad out to the home. So part of what Mayo and a couple of other, I'm not sure if Atrium is doing it too, but you can talk about it. They will send out somebody to get that set up for them and take that burden off of the 88-year-old to do that. So I think there are some incentives for adoption, but I think the key thing is that the physician who is sending the patient home with these devices or the caregiver who's sending actually can get paid because they're doing remote patient monitoring. And that just happened a few years ago. So it's not anything that's been out there for 100 years, but maybe I've been watching it for probably about 5 or 6 years, so it's been out there.
I'll just say quickly, I think the wearables need to become more wearable. They're quite frankly, at least the ones we're using for remote patient monitoring, continuous monitoring, they're not comfortable, they're not showerable, some of them. So there's a lot of work to be done, I think, in making the wearable more wearable.
Yeah, I also want to just draw the distinction between passive and active systems, and fear we're a little outside of AI, because this actually has nothing to do with AI. I just want to be very clear. This is just technology and usability questions among older adults, which is something I study all the time and love. But we strive to design passive systems, which means you can put something on the table and it just collects the data that you need. Unfortunately, a lot of the systems that we have access to right now are active systems, meaning you got to put a blood pressure cuff on, you got to push a button, and oh, you didn't push a button on the tablet first, well, you got to do it all over again, sorry. Really, how is it possible an engineer designed it that way? But that's how it got designed. And so, unfortunately, most of the systems we have right now are active, and that is what older adults and young adults actually often struggle with. And so when we do have a passive system, it works great. Like, the whole point is it's just sitting there in the background, it's collecting the data it needs to collect. I do just want to draw the distinction, though, that has very little to do directly with AI, other than we need AI to also be a passive system. Like, we can't have it need all these inputs and annotations and things like that. That is extremely challenging in both hospital medicine and home hospital medicine, because we don't often have the eyes that we need to be able to annotate the things that a lot of these algorithms need.
Hi, thank you for this. I'm really excited about the advances in the hospital at home, but I'm also really interested in that transition between you're out of the hospital, whether it's at home or not, into a chronic care situation. It seems like we know a decent amount from using things like continuous glucose monitors, which actually have some AI embedded in them at times. And so what can we learn from things that already exist that are integrated into our health systems that we can apply in either these acute settings or hopefully in that more pervasive monitoring? Are those in the works?
So there's a couple of things to consider. So continuous glucose monitors is a great example because they've kind of been tried and true and tested. The thing that hasn't happened yet is grabbing that data, putting AI on top of it, and then sending a trend to a monitoring caregiver. So it might be a chronic disease manager, whoever the institution or value-based program person is actually taking care of. So that piece needs to be more ubiquitous, and it is not quite there. It's possible. There are companies out there, to name a few, MEDITECH, Graphite, Xealth, there's Vicerion. They all know how to grab data from these devices. And there's one company that, when I worked at MEDITECH, I worked with called Remedy, who does glucose monitoring, and we were able to grab that data and put it on a dashboard for whoever the disease manager. So we just need to do more of it. So it's not that it's impossible. And what we also did with this particular vendor was put algorithms on top. I can't call them really AI because we weren't doing AI at the time, but there were algorithms to kind of look at the data and analyze it and give some perspective to the caregiver. So there are dozens and dozens of FDA devices, for better or for worse with regards to usability, but there are dozens of devices that we can do exactly the same thing as we're doing with the glucose monitors to do chronic disease management.
Sweet.
And I just say really quick, when we put on these monitoring devices, we're thinking of all things home as a continuum of care, from highest acuity hospital level care to chronic disease management and everything in between. We don't want patients confused with, well, now we're going to do this device, and then, well, let's take that one off because now you're in our home health program. We're going to put, this needs to become very seamless for patients, and that's a whole field of work to do.
Okay, we have 2 minutes left, so we can do 2 one-minute questions.
Quick question. Can you speak a little bit more about whoever looks at the data? Like, what is kind of the staffing model of who's looking at all the data as it comes from there, and how do you integrate that with the primary care physician of the patient?
Sure, great question. I would say it's highly variable, just like it's highly variable in hospitals across the country. So there are some hospitals, for example, that still have a very old-fashioned, telemetry nurse role, where literally there is somebody staring at lines going across the screen all day long and trying to recognize when there's a problem. Then there's hospitals that say, no, it's okay. We'll let the computer take the first pass at the data. If there's an alarm, then we'll have the human look at it. And then there's also some programs that actually are running a pretty sophisticated autonomous kind of evaluation of the data, and essentially like a human will very rarely look at it unless there is then that kind of yes, you're crashing, or no, you're not crashing. And so I think it really does vary. There are places that have entire command centers of people who just monitor these data all day long, and then it kind of swings all the way over to like a much more machine-driven approach. Again, we do not have the right level of evidence base to really say where we should be on the spectrum right now. That is like a lot of work that needs to be done, and frankly, I think I have a vision one day that there probably will just be a machine watching probably thousands of hospitals all at once. We are so far from that we still have like lots of nurse sitting in front of 10 computer screens watching telemetry go by, which I don't even know if that's safe either, because no one's ever tested that. And so, we don't have a lot of evidence base, unfortunately.
Okay. Last 1 minute question.
Hi there. You guys are my favorite speaker panel, because definitely I'm into hospital, home, or a new term I heard, home-based care today. But I pitched earlier that my smart bathroom system would be great for the kind of assistance that you guys are looking for, and I hope that I can get more information from you guys. And my smart bathroom system is definitely something that you guys are, I guess, looking for. All right, thank you.
Okay. Well, let's thank our panelists. Thank you very much.